All right, everybody. Looks like that we've got some folks that are logging in. That's good. Glad to see you here. Have I sent out the study guide for the final exam to you guys?
Yeah, you have.
Okay, good. All right. So let me just kind of share it on the screen with you so that we can go through it and you are able to kind of take a look at it. So you should see the EMC 225 final exam review. Is that coming up? Anybody?
Yeah, it is.
Okay. All right. So let's just, and this is being recorded. So let's just kind of go through this. One of the things that I will point out is we will not go through number 5 because this has basically already been provided for you in the PowerPoints. These are the drugs that you need to be familiar with as far as from drug profiles on the exam. Diphenhydramine or Benadryl, diazepam or Valium, dextrose 50, 25, and 10%, atropine, morphine sulfate, adenosine, epinephrine, albuterol, and tranexamic acid. So know every section of the drug profile that we went over, but you don't have to know everything about all of these drugs. So basically what I'm looking for from you guys, and this will be short answer, this will be just a free response of, you know, what is the category of the drug? What are probably 2, maybe 3 contraindications that I'm going to want to look for? Let's say 2, okay? 2 indications, 2 contraindications, 2 side effects that you might get for this particular get from this particular drug. And then you need to know the dosing regimen for the drug that I'm asking in a particular situation. And I'll spell out. So for example, if I'm asking you for either the cardiac dose of atropine or the organophosphate dose of atropine, I will tell you that. In some drugs, especially like with atropine, I'm probably going to ask you for both, but I will spell out for you exactly what I'm wanting you to do. Same way with epinephrine. Are we looking at the drug dose for cardiac arrest, or are we looking at the drug dose, say, for anaphylaxis? And so we'll kind of lay that out for you on that so that it will be pretty obvious. So let's kind of go through our word list of what you need to be familiar with. When we use the word, and this, for those of you that are in my 303 class and who have taken my 303 class, some of these first words should be very, very familiar to you. Chronotropy. What do we mean when we're talking about chronotropy? This is what
talking about the heart rate.
Yeah, so chronotropy refers to how fast the heart beats. Chronos, time, and this kind of indicates the faster the heartbeat, the more cardiac output will come about to a degree. The heart rate can get too fast, especially in SVT, of where you get kind of that law of diminishing return, and now it begins to come down. Again, one of the things I want you to be able to tell me if it affects chronotropy, I definitely in a description of the drug, I want you to tell me, if it has this effect, is it a positive chronotropic? Will it increase the heart rate? Or is it a negative chronotropic that will decrease the heart rate? And it'd be the same thing if it applies in regards for dromotropy as well as inotropy. So dromotropy refers to what?
The speed of the electrical impulses going to each other in the heart.
Yeah, so as we're going through this, keep in mind that what we're going to be seeing here is that the faster that the impulse, up to a degree, the faster the impulse goes through the heart, with all things being equal, the heart rate will increase as well. Okay, and that leaves us our last word on here as far as from a cardiac perspective, direct cardiac perspective, is inotropy. and that is the contractile force. Again, keep in mind that, for example, I may ask you a question about epinephrine and ask you, is it a positive or a negative inotropic force? Now, you've got 50-50 chance of getting that right, but I don't ever ask you just a question of where you have the 50% chance of getting it right. So I'm going to ask you to defend your answer if I do something like that, okay? Now, let me stop there for just a second. Anybody have questions or confusion about chronotropy, dromotropy, or inotropy? All right, hearing that, we'll move on. First pass metabolism is defined as when we give a medication by mouth, it goes into the digestive system, and the first thing that happens is it has to go through the liver. And the liver is, much like the kidneys, is a filtration type of organ. And as such, what it will do is that it will reduce the amount of medication that is available for the body to utilize. And that is known as first pass metabolism. So, Zach, in this regard, what would we do to help to offset any first pass metabolism?
You could give a greater dose of the drug.
Very good. Do you happen to remember what that whole procedure of giving a larger dose of the drug is called?
Is it a loading dose?
Perfect. Yep, you're exactly right. So many times we will give a loading dose of medicine that is still not going to be toxic, but what we'll do is it will raise that level up so that as it goes through the liver, now it brings it down and it will be right in that nice therapeutic index it's going to be for our patient. Okay, excellent. Allie, what does homeostasis mean?
Homeostasis is like the equilibrium of the body.
Yeah. So the body likes to be balanced. You know, we have a pH that runs between 7.35, 7.45. It likes to be just a little bit, not much, but just a little bit on the acidic side of that range. And the body is always working to try to maintain that homeostasis. If we begin to breathe too much and we blow off too much carbon dioxide, now what will happen is our respiratory rate will begin to slow down so that we can retain carbon dioxide, because that helps to balance and helps us to breathe at the right rate. Again, if we become too acid, the kidneys will come into play here and it will begin buffering out some of that acid to now kind of keep us in that balance. And that's the thing that the body is always trying to do, is to maintain homeostasis. Catherine, what does agonist in the world of pharmacology refer to?
Isn't that a drug with like positive benefits to it?
Yeah, not necessarily positive benefits, but when you give it, it causes something else to happen. So, for example, if we give epinephrine to a patient, now that's going to be a positive agonist towards increasing the heart rate or causing bronchodilation. So basically, an agonist causes something to happen. Okay, now it can be positive, and hopefully that's what we're doing when we're giving these particular medications, but often it can be negative as well. So, Catherine, let me stay with you to take the other one. What is an antagonist?
Would that be like if the medication doesn't do any side effects then?
You're close. Basically, as far as an antagonist or an anti-agonist is something that turns something off or blocks it. So, for example, let's think about atropine. What is the end result? And I'll throw this out to anybody. What is the end result of what we're hoping to do when we give atropine in the cardiac patient? Go ahead, Bella. You're okay.
Isn't it to block the acetylcholine receptor?
Okay, so that is the physiological perspective, and so that's what makes it an antagonist. It blocks those acetylcholine and it turns them off. So that what is the end result there, Bella, that will happen after we give?
So acetylcholine, it slows the heart rate, so the heart rate would raise up since it's blocking the action of the receptor.
Perfect. Excellent. Yeah. So basically one of the things we give, and we can give atropine for patients that have organophosphate poisoning, because that's going to be one of the things that we're going to see is that their heart rate is going to drop down really, really slow, as well as some other signs and symptoms. But basically what we're looking at here is it's going to block those acetylcholine secreting pumps, and it's going to turn them off. And by turning them off, now our heart rate comes up. So that would be an antagonist. Good, Bella. Zach, what is a beta blocker?
It's something that it's a medication that it combines to beta 1 and beta 2 receptors to stop the effects of beta 1 and beta 2.
Okay. So you're close. It didn't really have an effect on beta 2. So Allie, help him out a little bit. What does a beta blocker do?
It binds to beta receptors and it reduces chronotropy and inotropy.
Yeah, very good. Very good. So many times you will see patients after they've had a heart attack, or if you've got a patient that has been diagnosed with atrial fibrillation, they'll put them on a beta blocker. And what that does is it slows everything down. So it reduces chronotropy, reduces the heart rate, reduces inotropy, in and out contractile force of the heart. And so it is also utilized in conjunction with some other medicines to help bring down the blood pressure. Okay. So now, Zach, you're right. It does impact the beta 1 receptors, but it doesn't have anything to really do, not directly with a beta 2 receptors, because those are going to be found in the lungs. And so one of the dangers of patients that are taking beta blockers is if you think back, if you've gone through your EMT course, you should remember compensated, decompensated, and irreversible shock. And in compensated shock, the way the body initially compensates is it bumps up the heart rate. Well, part of the problem with patients who are who have beta blockers who are in shock is that heart rate will bump up against the beta blocker, and they can deteriorate really, really quickly because their heart rate doesn't go up fast enough to keep perfusion going to the rest of the body. Catherine, tell me what half-life is.
That's like the time it takes a drug to be out of the body, at least like 50%.
Good. And how many half-lives does it take for a drug to be considered to be completely out of the body?
3 or 5?
5. There you go. 5. So again, we've talked about adenosine. Adenosine has a half-life of maybe about 10 seconds. So that means that in 10 seconds, 50% of the medicine has already been metabolized. In less than a minute, all of that medicine is out of the body, as compared to another cardiac drug, amiodarone, which has got a half-life of about 75 to 80 hours. So it could take weeks for that medicine to be out of the body. Now, one of the reasons why half-life is so important to understand, actually, there's a couple. Number one is that it helps us know from a therapeutic perspective how long we can expect the direct impact of the drug on our patient to last. The flip side of that is going to be, it also helps us to understand how long, if the patient is suffering negative side effects, how long that could last as well. As we shared with you, and we talked about, and hopefully you'll go back and review for your exam, we know that adenosine causes a brief period of asystole, and it can cause your patient to have chest pain, dizziness, anxiety, hot flashes. But we also know that when we talk to our patient, we know that those side effects, for the most part, sometimes people are a little more sensitive than others, will be gone. in less than a minute, as opposed to amiodarone that they may have side effects for weeks after we administer that medication. Good. Now, Bella, speaking of side effects, tell me, what is a side effect?
It's something that happens whenever you administer a medication that's not the necessarily intended action of the medication. So
Okay.
like, for example, like with epinephrine, it's supposed to speed up chronotrophy and entropy, but a side effect could maybe be like anxiety from the increased heart rate.
Excellent. Very, very good. Yeah, you're exactly right. Now, sometimes we have positive side effects, but most of the time the side effects are going to be negative. Okay. And so again, as they're going through and they're doing testing on drugs, they try to look for the incidence of how many people have these different side effects and report them out. Good. Very good. Zach, tell me what a contraindication is.
Contraindication is a reason to not give a certain medication to a patient.
Okay, excellent. Good. Very, very good. So give me just one contraindication for nitroglycerin.
Blood pressure lower than 90 systolic.
Perfect. Excellent. Yeah, that's definitely going to be an absolute contraindication. Now, remember, we can have absolute contraindications. We're going to have relative contraindications. Absolute contraindications means no how, no way are we going to give it. You got a blood pressure, systolic blood pressure of 75, your patient's still having chest pain. We're not going to give nitroglycerin because one of the side effects, as we saw just a little bit ago, one of the side effects is that it can drop the patient's blood pressure. Okay. Now, that side effect can be a good thing or a bad thing depending upon the situation that we find our patient in. If our patient has a systolic pressure of 75 and we give them nitro and now we drop their systolic pressure down to 55, we're probably going to put our patient into cardiac arrest. Okay. So that's going to be an absolute contraindication. However, the example that we've talked about in class is, let's say that you've got a patient that's got blood pressure of 94. Okay. It's above 90, but just barely. Okay. And so one of the things that you might now want to take into consideration as far as this being a relative contraindication is look at the patient as a whole. Are they showing signs and symptoms of shock? Are they pale, cool, diaphoretic? You know, are they sweating when sweating would be inappropriate? Are they anxious? What's their level of consciousness? Even though you've got a blood pressure of 94 or higher in this particular situation, we probably are not going to want to give our patient nitro yet until we get that blood pressure up just a little bit higher. On the other hand, let's say you got a patient that's got a systolic in 94 and they don't have any of those signs and symptoms, okay? Then we're good to go. We have no qualms about going ahead and giving the medication. Now, let me stop there for just a second. Anybody have a question about absolute and relative contraindications? Okay. Allie, what's an adverse effect?
An adverse effect it's like a side effect. It's an unwanted like reaction to a drug that you administer, except for it's harmful usually.
Okay, good. Yeah, and that's what makes it different than a side effect, is that what happens here, this adverse reaction, is either number one, you can foretell that it's going to happen, or number two, it happens, but nobody saw it coming. And those side effects, those reactions are always going to be negative. Very good. Catherine, tell me what the therapeutic index means.
That's like, isn't that from when a drug has like the bad side effects to, I don't know how to word it exactly.
Okay, Bella, can you help her out? Because Catherine, you're on the right track. Bella, can you kind of fill in some of the blanks?
It's like the range for like the bottom end is like where a medication has no effect at all or isn't really effective on the patient. And then the top end of the therapeutic index is like where there is negative effects. So it's the in between, like the sweet spot.
Yeah, very, very good. Sometimes you'll hear it referred to, especially from older providers, called the therapeutic window, of where here's the bottom area of where it starts to be helpful. And then up in here somewhere is where it begins to get toxic. The closer those two come together, the more dangerous the drug is. So if someone says, hey, this drug has a narrow therapeutic index or a narrow therapeutic window, you got to watch patients that are on that drug really, really carefully. If they say it has a really wide therapeutic index, then it's relatively safe. Things like Tylenol. Tylenol is a relatively safe drug, so it has a really quite a wide therapeutic index in giving it. So your patient would have to take an awful lot of it to really come about and bring about any type of harm. Okay. So Zach, down to number 2. Tell me, what does nitroglycerin do as far as the vasculature of the heart?
It relaxes the vasculature, or not the vasculature, but it relaxes the vasculature of the heart.
Okay, and why is that both a good thing and a bad thing?
It can be a good thing because it will decrease the workload of the heart as long as the drug is in effect. And if you're having a heart attack due to like increased O2 demand, that will help lessen the effects of it. But it can be a bad thing for the same reason, is it's decreasing the workload of the heart. So your heart's not beating as much. So it's going to decrease perfusion.
Okay, yeah, and the decreased perfusion comes about as a result of one of the primary side effects of nitro, of dropping that blood pressure. So yes, very, very good job on that one, Zach. It does cause vascular dilation, which decreases the workload of the heart. The other thing that it has in there, and this would be important to remember, is that again, we give nitro to a patient that's having chest pain because they've got some type of a blockage in one or more of the arteries of the heart. And so what we want to do is we want to dilate those arteries to get more blood around that blockage. And so it's going to perfuse on the distal side or on the far side of where that blockage is going to be. So kudos as far as dropping the workload of the heart. Very, very true. The other thing is it's going to increase the oxygenated blood beyond where the blockage is going to be. Like I said, the bad side of this is going to be that it's going to potentially drop your patient's blood pressure. So we kind of want to watch that really, really quickly. Allie, why does our patient's blood pressure drop after we give morphine? There's 2 reasons.
Hypotension occurs after you administer morphine because it causes a massive release of histamine throughout your body.
Number 1.
And it decreases the vasomotor centers in your brain.
Which results in what?
Vasodilation of peripheral vasculature.
Perfect. Yeah. So basically, the arteries go from here to here. Okay. And so they get large. When our arteries dilate, blood pressure drops. But wait, there's more. That massive release of histamine will now cause some of the plasma to begin to leak out, which again drops even more of the volume that is within the arterial system, bringing the blood pressure down. Now, that doesn't necessarily mean that we're not going to use morphine. Okay. Sometimes we may give morphine, especially if we got a patient in pulmonary edema, that we need to pull some of that fluid off of the lungs by doing just that very thing. Vasodilation and little tiny holes that develop within the vasculature to cause a leakage out of some of that blood or some of that plasma. But that can also cause us a problem. So I hope you're beginning to see here that medications that we administer is kind of like the Force from Star Wars. It has a light side and a dark side. So it has good actions that we can see, but that same medicine can also bring about some really, really bad actions. Okay. Now, Catherine, okay. Number 4 says make a cogent argument. Cogent just is a big fancy word that says a rational or logical argument as to why or why not you would give nitroglycerin to a patient with a right-sided MI. So first of all, let me ask you a question. Would you give nitroglycerin to a patient that is having an MI in the right ventricle?
I would think you wouldn't.
Okay, tell me why you would. Now defend your answer for me.
I'm honestly not too sure.
Okay, all right. Let me just throw this out to anybody. Does anybody have a rationale as to for or against giving nitro to a patient with a right-sided MI?
I think it depends.
That's a good start. Tell me more.
Because I think it depends on like the way the patient's presenting, because nitro decreases the preload returning back to the heart. So I feel like I just really think you need to seriously like evaluate the patient's presentation and like their vitals to see if like if their BP is above 90 and to make sure all the other things are in check to see if like it's gonna negatively, like seriously negatively affect them, I guess.
Okay, very, very good. Allie, were you going to share some wisdom?
Yeah, I guess my question is, why would you give it? Because, I mean, even if the blood pressure is not that low, it's gonna drop your blood pressure, which is gonna decrease preload, which the right-sided AMI is dependent on. So I don't understand why you would give it.
Okay, good question. So let's talk about this. The correct answer is the very first word that Bella says in her answer is it depends. Okay. Now, Allie, you're exactly right. We give nitro to a patient, it does decrease the preload. The right ventricle is preload dependent as far as keeping blood flowing through there. If we give our patient nitroglycerin, yes, it is going to cause vasodilation. It's going to drop the preload, which could, emphasis here on the word could, lead to a life-threatening hypotensive crisis. We could drop the blood pressure low enough that our patient could potentially go into cardiac arrest. But now the flip side of this is going to be here. If we don't give the patient nitroglycerin, from a physiological perspective, what's not going to happen?
Their blood pressure won't decrease.
Right, it won't decrease because what else is not happening? We'll play 20 questions here.
Because the oxygen isn't getting perfused. So like the AMI, that the last part of it's infarction. So if you're not giving it to them, then the right side is just going to start dying. And like you always say, you want to treat what would kill the patient first.
Excellent. Very, very good. Yeah. So again, this is one of those situations of where we're pretty sure, especially if we do a 12 lead and we're able to look at that, and you'll learn more about that in advanced sequence, that if we don't dilate that vessel, there's no blood that's going to get through and our patient's heart muscle is going to die. Remember, dead heart tissue that scars over cannot contract, so there's no inotropy, and it cannot conduct electricity, so there's no dromotropy. We get a large amount of heart tissue that dies off. Now it's going to have a very, very negative impact on our patient's quality of life. So here's what we do, all right? Our patient has a right-sided MI. we're going to make sure that we get our line started first. And we should always get an IV started prior to giving nitroglycerin. Again, it's much easier to get an IV started when you got a blood pressure of 120/80, as opposed to when you give nitroglycerin and the blood pressure now drops to 90/60. So get that line started, use a fairly large gauge IV catheter, and go ahead and give the patient nitroglycerin, even if you've identified that they're having a right-sided MI. If the pressure drops, that's because the vasculature has dilated and there's not enough fluid in there to keep the pressure up. So what we're going to do in this situation, we're going to lean over, we're going to open up our IV solution, and we're going to give our patient a bunch of fluid, which is going to, guess what? It's going to take the vasculature and fill it full of IV fluid. And now what happens to our blood pressure? Blood pressure begins to come up. It begins to rise. Now, our patient's blood pressure is fine, so their level of consciousness is doing better. And wait, there's more. Our patient is still getting the benefits of the dilation of getting more oxygenated blood distally through that. Now, let's think of it this way. I know some of you guys are EMTs and some of you aren't, but understand within the EMT scope of practice, can you, as an EMT, help a patient take their nitroglycerin? Yes or no?
Yes, if it's their
Okay.
prescription. Sorry.
If it's their prescription, yep, you sure can. You can help them take it. Now, let me ask you a question. As an EMT, how are you going to know if that patient's having a left-sided or a right-sided heart attack?
You don't.
You're not going to, because in Kentucky, you can EMTs can acquire 12 leads, but they can't interpret them. Okay, so why would we go from just blindly kind of like Oprah, you get nitro, everybody gets nitro, to now you're given some additional skills and you can identify even when a patient is having a right-sided MI, but we're going to deny them the benefits for that. Now, if you've got a patient that's having a right-sided MI and their blood pressure is already really, really low, get on your phone or your radio with your ER med control and do a consult. If it's, basically if it's below 85 systolic, your doc's probably going to say, let's wait just a little bit and see if we get the blood pressure up. And he may order you, or she may order you to give a fluid bolus for this particular patient. And so the key here is, and this is extremely important, is the answer is it depends. Don't reject outright giving nitro to a right-sided MI because you may have heard some erroneous information from other paramedics. So now, ladies and gentlemen, that brings us down to our drug profiles, and I've already shared with you kind of what I want you to know about those. That's everything that I've got, but I want to stop for just a minute and see, do you have any questions or concerns about the exam that I can help you with now?
Is the whole thing gonna be like short answer?
It's a bit of combination of multiple choice and short answer, maybe a few matching, something along that line. It'll be similar to what you've seen in your previous exams. Anybody else?
For the nitroglycerin, or for the nitro question for the AMI,
Mhm.
The last time that we had that question, I got it wrong because I argued for a side. I was just clarifying for this question. It says argue for or against. Will it be okay if you argue against or for, or would you rather us explain why you can do both?
Well, basically what I want you to do, again, the reason I kind of put that in there is I want you to, okay, let's do this. Okay, let's do a little bit of a change here. Okay, I'm going to say, to make a cogent argument for the administration of nitroglycerin to a patient with a right-sided MI, and go through that whole process of what we just did as to why we would give it to a patient with a right-sided MI. Keeping in mind that again, what I would like to see in your response, and again, I'm not going to ask you to write a dissertation, so 2 or 3 sentences is going to be fine as long as you cover all the pertinent points, is to go in there and to be able to identify that, yeah, we've got to open up the artery. And if the blood pressure drops, we're going to give our patient a fluid bolus, which will bring the blood pressure up, and we're still getting the benefits of the nitro for the hypoxic tissue. Does that help, Allie?
Yeah, that makes sense.
Okay, good. Anybody else? All right, guys, hearing none, I'm going to convert this video. It'll take me a little bit of time. I will post it on the announcements page of your Blackboard class shell. And then I'll also send the link out. Now, here's the thing, and this is true for anybody that's joining us live today, or if you're watching the video later on. If you got questions, email them to me. Okay, nights, weekends, I'm always checking my email, and so let me know so that I can kind of help clear up any confusion that you've got. So, again, look at your date that you would have. I don't have it here in front of me. It will be up in Stratton 286. You'll have 2 hours for the exam. I'm not building an exam that will normally take 2 hours, but you will have the entire 2 hours. So there won't be any reason for you to rush. And everything will be coming from this study guide that I've shared with you. Okay. All right, go enjoy the rest of your afternoon. If you need something, let me know, okay?